Welcome to our educational video on emphysematous pyelonephritis, a severe and life-threatening infection of the kidney. In this video, we will explore the causes, diagnosis, and treatment of this condition. Our goal is to provide a clear and concise understanding of this complex disease. Emphysematous pyelonephritis, or EPN, is primarily caused by bacterial infections. The most common culprit is Escherichia coli, accounting for the majority of cases. Other bacteria such as Klebsiella pneumonia, Pros mirabilis, and various fungal species can also be responsible, although less frequently. A significant predisposing factor is poorly controlled diabetes mellitus. The high glucose levels in the urine provide a fertile environment for bacterial growth and gas production. Urinary tract obstructions, such as kidney stones or structural abnormalities, can also increase the risk by impeding urine flow and promoting bacterial stasis. The hallmark of EPN is gas formation within the kidney tissue. This occurs when the infecting microorganisms ferment glucose and other substrates, producing gases like carbon dioxide, nitrogen, hydrogen, and methane. These gases accumulate within the renal parenchyma, collecting system, and surrounding tissues. This gas formation disrupts kidney function by causing tissue necrosis, inflammation, and potentially septic shock. The infection can also spread beyond the kidney, leading to perirenal abscesses or systemic complications. Furthermore, the inflammatory response triggered by the infection can damage the kidney's filtering units, called nephrons, impairing its ability to properly regulate fluid and electrolyte balance. EPN is a relatively rare condition, but it is more frequently observed in individuals with certain risk factors. The most significant risk factor is diabetes mellitus, with approximately 70–90% of EPN cases occurring in diabetic patients. Women are also more susceptible than men, likely due to the higher incidence of urinary tract infections in women. Advanced age and immunosuppressed states, such as those resulting from organ transplantation or chemotherapy, also increase the risk of developing EPN. Geographic location may also play a role, with some studies suggesting a higher prevalence in certain regions, potentially due to variations in diabetes management and infection control practices. The signs and symptoms of EPN can vary in severity but often include fever, flank pain, and dysuria, which is painful urination. Patients may also experience nausea, vomiting, and generalized weakness. In severe cases, patients may develop septic shock, characterized by low blood pressure, rapid heart rate, and altered mental status. It's crucial to note that not all patients will present with all of these symptoms, and the presentation can sometimes be subtle, especially in elderly or immunocompromised individuals. Therefore, a high index of suspicion is essential in at-risk patients. Diagnosing EPN requires a combination of clinical evaluation and imaging studies. A urine analysis is usually performed to identify the presence of bacteria and white blood cells, indicating an infection. Blood cultures are also typically obtained to assess for bloodstream infection. The cornerstone of diagnosis is imaging, with computed tomography, or CT scan, being the preferred modality. CT scans can clearly visualize the presence and extent of gas within the kidney and surrounding tissues. Plain abdominal X-rays can also detect gas, but they are less sensitive than CT scans. Ultrasound can be used as an initial screening tool, but its sensitivity for detecting small amounts of gas is limited. EPN is often classified based on the severity of the disease and the extent of gas involvement in the kidney and surrounding tissues. Several classification systems exist, but one commonly used system categorizes EPN into 4 classes. Class 1 involves gas in the collecting system only. Class 2 involves gas in the renal parenchyma only. Class 3 involves extension of gas or abscess to the perinephric space. And Class 3B involves extension of gas or abscess to the perinephric space. Class 4 is defined by bilateral EPN, or a solitary kidney with EPN. This classification is important because it helps guide treatment decisions and predict prognosis. The treatment of EPN typically involves a combination of antibiotic therapy and drainage of the infected area. Broad-spectrum antibiotics are initiated empirically to cover the most likely bacterial pathogens. The choice of antibiotics is guided by local resistance patterns and culture sensitivities once available. Drainage can be achieved through percutaneous nephrostomy, which involves placing a catheter into the kidney to drain the infected fluid and gas, or through surgical nephrectomy, which is the removal of the affected kidney. Nephrectomy is usually reserved for severe cases with extensive tissue destruction or when conservative measures fail. In addition to these interventions, supportive care, including fluid resuscitation and blood pressure management, is crucial, especially in patients with septic shock. Early and aggressive management is essential to improve outcomes. Preventing EPN primarily involves managing the underlying risk factors. Strict glycemic control in diabetic patients is crucial to reduce the risk of infection. Maintaining good hygiene and promptly treating urinary tract infections can also help prevent EPN. Patients with urinary tract obstructions should undergo appropriate evaluation and treatment to restore normal urine flow. Additionally, educating patients about the signs and symptoms of urinary tract infections can facilitate early detection and treatment, potentially preventing progression to EPN. The prognosis of EPN depends on several factors, including the severity of the disease, the patient's overall health, and the timeliness of treatment. Early diagnosis and aggressive management are associated with improved outcomes. Historically, EPN carried a high mortality rate, but advancements in diagnostic imaging and treatment have significantly improved survival. Recent research is focusing on identifying novel biomarkers that can predict the severity of EPN and guide treatment decisions. Furthermore, studies are investigating the role of minimally invasive surgical techniques, such as laparoscopic nephrectomy, in the management of EPN. These advances hold promise for further improving the prognosis and quality of life for patients with this challenging condition.